afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on a collaborative approach to developing chronic disease prevention program outcome indicators. My name is Andrea Bodkin, and I'm a Senior Program Specialist at Public Health Ontario, and I'm very excited to be moderating today's session. Today I'm coming to you from Wiskotanach, which is the Anishinaabe word meaning burning bright light. Today we recognize Wiskotanach as the Don River and Don Valley in Takaranto, or Toronto, and Treaty 13 territory. And today we have people joining us from across Turtle Island and beyond. I'd like to acknowledge the land, the waters, the first peoples who inhabited them. And I'd also like to recognize our responsibility to care for the land and respect the peoples who live upon it. A few years ago, I learned about a teaching called two-eyed seeing, and that's where with one eye we view our Western way of knowing and seeing and learning, and with the other eye we consider Indigenous ways of knowing and Indigenous knowledge. So I'd like to offer you a gentle challenge today as you listen to today's webinar to consider seeing from both eyes and applying the knowledge that's going to be shared with you today, considering how you can share that from a First Nations, Inuit, and Métis perspective. Before we get started on the webinar, just a couple of housekeeping things. If you require your CME credits, please email capacitybuilding@aohpp.ca. I'd like to state that as a moderator of the session, I do not have any conflicts of interest. And now I am very happy to introduce the speakers for today's presentation, Shannon Robinson, Kim Harding, and Vincent Ng, who are going to be speaking about the work that they've embarked on as a locally driven collaborative project. Shannon Robinson is the Director of Health Promotion at the Thunder Bay District Health Unit, and she has over 20 years of experience in local public health and health promotion. Kim Harding is a Doctor of Public Health student at the Dalai Lama School of Public Health at the University of Toronto, and she is also an independent consultant in global nutrition research and programs. And Vincent Ng is a public health nutritionist with the Thunder Bay District Health Unit. I'm so looking forward to hearing all about their collaborative research today. Shannon, please start your presentation.
Thanks, Andrea, and welcome everyone. I am so pleased to be here today presenting on our locally driven collaborative project to develop a core set of chronic disease prevention indicators. It's been challenging and rewarding work, and we are grateful to have this opportunity to share with you. I'm duly noting that today's content was created by our team and that Public Health Ontario assumes no liability for the materials. As Andrea mentioned, Kim, Vincent, and I are your presenters today, but I also want to acknowledge that the other members of our core project team are also on the webinar today, and we will introduce them in a subsequent slide, though they aren't able to come on the screen. An additional note before we get started, Kim Harding is a paid consultant for Nutrition International, and no other presenters have real or potential conflicts to report. On the screen, you'll see our learning objectives. Today, we're going to talk about performance measurement, our experience with our locally driven collaborative project, our results, our learnings, and our next steps to further this work. I want to start with a little bit of background on the work we're presenting today. If you're associated with a public health unit in Ontario, you know that currently for chronic disease prevention programs, each public health unit develops a program of local public health interventions to meet the Ontario public health standards, and then reports on that program differently through annual reporting to the Ministry of Health. This makes demonstrating impact challenging. Having no standardized set of indicators is problematic and makes showing the value of our work in these program areas very difficult at the provincial level. In early 2023, we successfully applied for a locally driven collaborative project on research that would strengthen public health programs and interventions impacted by the pandemic. Locally driven collaborative projects bring together public health units, academics, and other partners to do applied research in an area of shared interest. We know that even though chronic disease continued to carry a very high burden of morbidity and mortality throughout the pandemic, during the response, many health units stopped most or all of their chronic disease prevention programming. We pursued this opportunity with the intent of developing a core set of chronic disease prevention indicators to help document the value of chronic disease prevention programs and ideally help sustain them through the next emergency response. Our core team was led by myself from Thunder Bay District Health Unit and Aaron Salewski at Ottawa Public Health. From Thunder Bay District Health Unit, Joanna Karastathis and Vincent Ng worked on the project, We also had a project coordinator, Kristen Beaton, for the first half of the project. The project continues to have tremendous support from the University of Toronto's Dalla Lana School of Public Health through Dr. Erica DiRuggiero, Kim Harding, and Jareera Mohammed, as well as our honorary core team member from Public Health Ontario, Dr. Sarah Orr. We established a formal advisory committee which provided input and guidance through the various phases. The group was instrumental to the project and has our many thanks. We also used working groups to help us interpret data and move the work forward. These additional working groups were made up of 5 to 6 health unit representatives. And throughout the project, we periodically connected with the Ministry of Health. I'm now going to turn it over to Kim to get us more into the methodology and the results.
Hey, thank you, Shannon, and hello, everyone. Thank you for joining us today, and I'm very happy to present on behalf of the group. So we divided our project into 3 phases, each with specific research questions that we sought to answer. The first phase was a compilation of best and promising practices, where we reviewed what others have done or recommended in order to inform our process and options for indicators that we could be using. The second phase, we undertook a priority setting exercise to develop standardized nutrition program indicators. So nutrition was chosen as an exemplar chronic disease prevention topic because we only had time for one topic, and that was where a lot of the expertise within the core group lie. Finally, in the third phase was an evaluation of the process that we used. So the project is creating indicators for the purposes of performance measurement, which we are defining as the ongoing monitoring and reporting of program accomplishments, particularly progress towards pre-established goals. A performance indicator, then, is a specific quantitative representation of a capacity, process, or outcome deemed relevant to the assessment of performance. So indicators, or performance indicators, tend to be quantitative, as this definition suggests, but qualitative information or indicators are also another really important source of information about a program. So there are different types of indicators that relate to performance. Program indicators, shown here in the blue box, can be used to directly assess performance of a program. They can be operational or results-based. Our project intended to focus on results-based indicators, so that includes short to medium-term outcome indicators that measure changes that a program is intended to achieve amongst those targeted by the program. Whereas population indicators on the right outside of the blue box measure changes in health outcomes amongst a whole population, which are typically longer term. And these are out of scope for our project, in part because these changes can't necessarily be attributed to a public health intervention. I'll just note here that there are many different terms and definitions used. This is just what we've used to guide our project. We also have an equity-focused version of this framework that we've been using. So in phase 1, we used an environmental scan to compile candidate indicators. We did this for 7 topic areas identified at the start of the project: nutrition, physical activity, alcohol use, tobacco use, mental health, social determinants of health, and adverse childhood experiences. In total, we collected over 4,000 indicators, mostly from health units' annual service plans since 2018. Our topic for the project was nutrition, though, so for now, we put all the indicators for the other topic areas aside, removed duplicates, any out-of-scope indicators, process output, population outcome, and that left us with 151 candidate nutrition program outcome indicators. So in phase 1, we also used a rapid scoping review to compile information on the development, selection, and prioritization of indicators for measuring public health and healthcare performance. So for this piece, we went beyond chronic disease prevention and included healthcare, just in case we couldn't find enough information. So we focused on the process for developing indicators, criteria for selecting or prioritizing indicators, and also if we came across any performance indicators for public health chronic disease prevention programs, we also used those, and those fed into the environmental scan mentioned earlier. We used only knowledge synthesis products, such as systematic reviews, because of time limitations, and we included both academic and gray literature. In total, we had over 1,700 reports in our search results, and after applying our eligibility criteria, we included and extracted information from 53 reports. So from the extracted information, we identified several key steps in the process for developing indicators. So the first being planning. This includes, for example, starting with a clear understanding of the purpose and goals and how indicators will be used and by whom. The next being engagement and consultation with key stakeholders. So for example, this would involving a wide or diverse range of key stakeholders throughout the process and being clear about expectations. Then identification of potential indicators. So for example, this step starts with identifying or developing a framework, a performance measurement framework to guide the development and organization of indicators, and also building an inventory of potential indicators. Next is the selection of indicators. So this involves using some form of consensus process, which considers input from stakeholders and establishing criteria for selecting indicators. And then the last step is confirmation of the selected indicators. So this can involve validating and field testing the indicators with the end users. A cross-cutting factor that we also identified is leadership. So the importance of clear and consistent and visible leadership throughout this process. We also identified some additional steps that may occur after the indicators are developed. So for example, orientation or training on indicators. So we already had a plan, had started the process when we, compiled this information, but it was still very useful to cross-check against. For the most part, it, validated what we were already doing or what we were planning to do, but it also helped us identify gaps and limitations, and also guide plans for future work beyond the official project. So in our rapid scoping review, we identified about 250 criteria for selecting or prioritizing indicators. Most were criteria that could be applied to individual indicators. We consolidated those into a shorter list of 48 by removing duplicates and combining similar ones, and then grouped them into 6 key categories shown here. And I'll just give you a few examples. We don't have time to go through each one. But for example, under importance and relevance, is what the indicator measuring under control of the organization? Under scientific soundness, is the indicator valid or does it actually measure what it intends to measure? Under data quality, which falls under scientific soundness, for example, are the data that feed into the indicator accurate? Under feasibility, for example, are data available for this indicator? Under interpretation and application, for example, does the indicator provide meaningful information? And finally, there was not a lot relating to equity, but we did include it as a cross-cutting category. So for example, does the indicator provide information about an equity-denied population? So we also found criteria that can guide the selection of indicator sets. So in performance measurement, typically you're using a group or a set of indicators, and how you think about each individual indicator might be quite different than how you think about the set as a whole and compiling and selecting the indicators. So for a set, you may want to ensure, for example, that it is comprehensive and covers all the outcomes of interest and that there are a manageable number of indicators. And I'll explain in the coming slides how we used the criteria we identified through the scoping review. So in phase 2, we undertook a priority setting exercise to develop a set of nutrition program outcome indicators. So this involved 6 key steps. We started with planning, which was an ongoing and iterative process throughout the life of the project. And I'll go over steps 2 through 6 in the following slides. So step 2 was developing an indicator shortlist. So if you recall from the environmental scan, we had a list of 151 candidate nutrition indicators, but that was just too long for a prioritization exercise. So we convened a working group comprised of core team and advisory committee members and also other nutrition experts from participating health units. The group determined which criteria from the rapid scoping review to use as selection criteria in order to narrow that long or full list down to a short list. So they applied the criteria shown here: necessity, amenable to change, under PHO control, clear and detailed, collectible data, useful, and applicable across health units. And so this resulted in a short list of 35 nutrition program outcome indicators for prioritization. And how those indicators were categorized is also shown here. So the next step in the process was prioritizing this list, the short list of 35 indicators. We conducted an online survey with health units. We requested 1 response per health unit and encouraged consultation with relevant colleagues. We shared the short list of 35 indicators and asked for feedback. So as part of this, we determined which prioritization criteria from the scoping review to use, and we chose relevance, feasibility, and usefulness or usability. So in the survey, we asked about the relevance and feasibility of each indicator. We asked about whether they were expected to use the indicators and reasons for not using indicators. We also asked what their top 10 would be of the list of 35. Also how equity could be considered in the indicators and any missing indicators. And for this survey, as well as an evaluation survey that I'll speak about later, we obtained ethical approval from U of T's Research Ethics Board and administrative ethics approval from PHO based on an administrative review. Okay, so 33 or 97% of health units completed the survey, which we were really pleased about. It's a very high response rate. most, so 32 of these 33 consulted within their health unit as part of their response to the survey. We ranked the indicators using the survey responses to the questions based on the prioritization criteria, and then we used this to divide the list into like top, middle, and bottom third ranked. There are 11 top ranked indicators. On the left shows how they were categorized, but in many cases, they actually could have fallen into more than one category. And actually 9 of the 11 indicators captured information about PHO partners or partnerships. On the right shows the most commonly reported reasons for choosing the top 10 indicators, that they reflected an upstream approach, feasibility and relevance, and also that they aligned with current practice or anticipated short-term future practice. We also asked how health equity could be captured by the indicators. So I'll go through just a few examples of some key themes we identified in the responses to this question. So one that relates to program design, for example, was to design programs with equity in mind from the start. A key theme that relates to indicator development is for indicators about partners to provide information about the types of partners. So for example, whether they represent equity denied groups. A key theme that relates to data collection and reporting is to consider equity in how data are collected. So, for example, ensuring appropriate translation where needed. And one important point to take away from, I think, the feedback that we received is that there are many ways to consider equity in the performance indicators, including going beyond what might be the most sort of obvious step or option of data, disaggregation of data. So we have a lot more information from the prioritization survey. This is just a quick overview of some of the key findings that we used. So the next step after the prioritization was we convened another working group which reviewed and discussed this prioritization survey findings at great length, I would say. And we used that information to create a preliminary nutrition program indicator set. And that ended up including 6 core and 3 optional indicators. So the idea for the core indicators is, once finalized, they should be relevant to and used by all health units, whereas the optional indicators would only be used if they were relevant. So these indicators ended up being revised quite a bit. So we won't look at them in great detail, but I'll just highlight that 5 of the 6 core indicators captured information on health unit partners. So after developing this preliminary set of indicators, the next step in the process was to evaluate the indicators. So we conducted another online survey, an evaluation survey. Similar to the prioritization survey, we invited all health units to participate. We asked for 1 response per health unit, and we encouraged consultation amongst relevant colleagues within the health unit. So in the survey, we shared and asked for feedback on the preliminary indicator set that I shared on the previous slide. And we also asked for feedback on the process that we used to develop these indicators, and I'll share those findings a bit later in the presentation. So 29 or 85% of health units completed the evaluation survey. Not as high as the prioritization survey, but still a very good response rate. And I'll share just some of the key findings here. So almost 3/4 of health units were either somewhat or very satisfied with the core indicators. So just over 1/4 were either neutral or not satisfied. We also asked about the likelihood of using each indicator. So for the core indicators, about 60 to 80% of health units were either somewhat or very likely to use the indicators. For the optional, these figures were a little bit lower, as to be expected. And by far, the most common reason for not using the indicators was measurement, like anticipated measurement challenges or difficulties. We also asked about barriers and enabling factors for using the preliminary indicators. So some examples of key themes we identified for barriers include capacity. So for example, limited registered dietitian staffing. Also concerns about the focus on counting the number of partners the health units collaborate with. And, for example, how meaningful this information is. Another barrier was uncertainty around provincial priorities, especially not yet having the new OPHS. Examples of enabling factors include support or guidance for using the indicators, incorporation of qualitative indicators or information, and also if there was harmonization across the province and everyone was using the indicators. So again, we had a lot more information from the evaluation survey, but that's just a quick overview of some of the key findings we used in our process. So for the last step in the process, we formed another working group to use the feedback from the evaluation survey and then refine the preliminary indicators into a proposed set. We're not saying final yet because there's still a bit more work to do with the indicator set. So as part of this, we actually also used feedback that we received about the indicators at a topic workshop that we held about our project in March. And as part of this step, we used a health equity lens to incorporate equity considerations into the indicators. So we ended up with 4 overarching indicators, each with sub-indicators and a narrative. And the indicators are at the health unit level, but they could also be rolled up to the provincial level. So the indicators themselves would be slightly different depending on the level of use. I'll briefly go over each one, but just note first that the way we ended up structuring our proposed indicators was based in part on a previous LDCP that developed standardized health equity indicators. And it was really helpful to have that previous example and the documentation of that project to refer to. So the first indicator is the number of partnerships the health unit has on food and nutrition related interventions. There's a sub-indicator for the strategies used through these partnerships based on the Ottawa Charter. So for example, creating supportive environments. Another sub-indicator for the food and nutrition topic area. So for example, food insecurity, and also whether any other public health topics are covered by the partnerships as well, either within chronic disease prevention or beyond. Also, the settings the partnerships are seeking to create change in. So for example, schools. Also sub-indicators on the percentage of these partnerships that are aimed at equity-related objectives and that involved equity-denied groups, and a narrative. So that could include, for example, any change or outcome as a result of the work and any relevant locally developed indicators. So the next indicator is whether the health unit is involved in work to create supportive food environments. So this is just a yes, no at the health unit level, but just to give an example, this could be rolled up to the provincial level and provide a number and percentage of health units involved in this work. Sub-indicators here are settings and also whether a health equity lens is used for the work and a narrative, following a similar approach as described before. The next indicator is whether the health unit is involved in the process for building healthy public policies related to food and nutrition. And there are sub-indicators for the topics and settings, and again, a narrative. And finally, the final indicator is whether the health unit monitors food affordability. And there's a sub-indicator for how the data are used. So for example, for education or advocacy for policy development, and also a narrative. So I've just shown a very high level overview for each proposed indicator. We've created a draft data entry tool with more details, including definitions, so we're in the process of creating a draft data entry tool with more details, including definitions of key terms and also some preliminary guidance, including response options for the relevant sub-indicators. So next, I'll share a few findings about feedback on the process from the evaluation survey. So there was a very high satisfaction with the process we used to get to the preliminary indicator set. 93% were either somewhat or very satisfied. And we also got a lot of very helpful feedback on the process. So I'll share just some examples of key themes that we identified in the responses to the questions asking for feedback. So in terms of what worked well, for example, the leadership of the core team and the participatory process that we followed. To improve the prioritization survey, there were suggestions, for example, to have fewer indicators and a shorter survey. 35 indicators and several questions about each indicator ended up, resulting in quite a long survey. To improve the development of the indicators, there were suggestions to not use existing indicators as a starting point, as that was, somewhat restrictive. And to improve the overall process, for example, there were suggestions for more involvement of other relevant contributors, such as ODPH. Finally, there were suggestions for continuing the work after the official project ends, including continuing to refine the nutrition indicators. So in the evaluation survey, we were also asked respondents to choose or suggest topics that should be prioritized for future chronic disease prevention indicator development. So as I mentioned at the beginning, nutrition was chosen as the topic to sort of develop and test a process and, that first attempt to creating a standardized indicator set. But the idea is that in the future, we would, apply learnings from this experience and to other topic areas to create standardized indicators for other chronic disease prevention topics. So in response to this question, the top choice by far was mental health. So over 3/4 of the responding health units selected this topic, followed by built environment. And this information will be used to inform decisions about what topics to do in the future. So to summarize, we started with over 4,000 potential indicators from our environmental scan for all of the selected chronic disease prevention topics. We pulled out nutrition indicators and consolidated those into a list of 151 candidate nutrition program outcome indicators. We then applied selection criteria from a rapid scoping review to narrow this down into a short list of 35 indicators. We then used feedback from our prioritization survey, which included criteria from the rapid scoping review, to bring this down to a preliminary set of 9 indicators. And finally, we used feedback from the evaluation survey to refine that preliminary set of 9 into a proposed set of 4 overarching indicators, again, each having sub-indicators and a narrative. So I think overall, everyone was, quite pleased with the process and what we managed to achieve, although the work is not done yet. But there are limitations to, to the work that we have done. And I'll just go over a few examples of important ones. So for what we set out to do, we did have a very limited time frame. I mean, we did have strategies in place to mitigate, but it was compressed and did affect what we were able to accomplish and the steps we were able to take. Also, there was no guiding performance measurement framework that we could use. So if you recall from, information that we've obtained in the rapid scoping review on process to follow, like a key step of that was having or developing an overarching framework to guide indicator development. An individual program might use a logic model as a framework to develop indicators, but that simply doesn't exist for the province. And there's a lot of diversity in what health units across the province do and how. And there's some, structure and, for example, suggested more generic outcomes in the standards, but that wasn't sufficient. That's not, sufficient for developing a full performance measurement framework that then indicators could be developed based off of. So we lacked this guiding structure, and that was a barrier to creating a comprehensive set of indicators. Also, as I mentioned from the start, we did aim to create program outcome indicators. That isn't necessarily where the process led us. Some indicators, depending on the program objectives and, perspective and definitions used, some indicators might be categorized differently. And we ended up just not being too restrictive with our indicator definitions. And we tried to follow the list that we started with and the feedback that we received the best that we could. Also, while we did think about equity throughout, we weren't able to fully consider health equity until the end when we had like semi-finalized indicators. But this left us with limited time for this step and perhaps led to different results than if we had used a different approach for considering equity. So now I will pass it over to Vincent, who will share some reflections on the process that we used.
Great. So I'd like to share a couple of reflections on this indicator development process, particularly going from the 151 down to that short list of 35. But also we considered these things in the later processes as well. So the first reflection that I had was that there was just a wide range of indicator quality. So when we looked at those 151 indicators that were used across the province, and we had some criteria that we were using to evaluate that, which is shared here on the slide, we found that not a lot of indicators actually hit all these criteria. And I think that speaks to the need to support performance measurement in chronic disease prevention. But I want to point out not only was there a wide range in indicator quality, but there was also a range in different variability in frameworks and priorities. So for example, some of the indicators referred to knowledge and skill development. And as we were discussing, we were noticing that some would say, well, that's a reason to exclude it because it's too downstream, whereas others would say that's part of a comprehensive approach. And so there's some different frameworks being used. The second reflection is that it was difficult to determine the scope of having a core set of indicators. So naturally, we wanted to be more specific in some ways because we wanted to be able to measure what the change was in certain areas. For example, advocacy on certain topic areas like food insecurity. On the other hand, it was really difficult to pick a core set of indicators based on specific topic areas. And so there's the tendency to zoom out a little bit and collect some more broad information, but without being so broad that we lose the meaning of it. Thirdly, we had some discussion particularly around the policy development piece, around where we would, or what stage in this theory of change or the logic model we would consider an outcome. So I think clearly implementing a policy would be, yeah, that's what we're going for, that's why we're developing it. But some of the discussion was that, well, sometimes you meet for a year or two and you just get to the point of putting this on the agenda. So is that only a process, or is it also, could it also be considered an outcome? And in our process, we decided that simply working on policy development, regardless of what stage they were at, could be considered an outcome, but that was certainly the attention. And we came to that conclusion also considering with policy development, as documented elsewhere, it's rarely a linear process anyways. A fourth reflection revolves around whether or not these indicators are so-called prescriptive or descriptive. And what I mean by that is, so clearly we're trying to work on improving how we measure what we do. You know, we have programs, we're trying to make a certain impact. Are we making the impact that we want to make? But the very act of going through this process on reflecting on how we're measuring things gets us going back to in that program planning cycle at the beginning of thinking about goals of, well, what exactly are we trying to achieve in the first place? And is that really what we want to be focusing on? And so just the act of trying to improve performance measurement brought us to also reflect on goals and to think both about, you know, how well are we measuring what we're doing, but also are we making the types of impact that we want to make in terms of what we're trying to achieve in the first place. And this phrase, we manage what we measure, I think captures some of that. And finally, we met over a number of meetings. We looked at these 151 indicators and tried to narrow it down. We were looking at different criteria for evaluating indicator quality, and yet equity rarely came up in those conversations explicitly without us bringing it into the conversation. And I think that just speaks to how focusing on equity takes intentionality, and that it's very easy sometimes to have conversations around indicator quality, so to speak, without considering how equity is considered. And going back to my previous reflection, considering it not only at the stage of program evaluation, but throughout the whole program planning cycle. So now I'm going to pass it on to Shannon to talk about where we're going from here.
Thanks, Vincent. Though the project funding has completed, there is still interest in building on next steps. So we've committed to test the proposed final set that we've come up with public health units and continue that refinement, and Kim has mentioned that. We're going to continue to liaise with the Ministry of Health and discuss opportunities for potential use of the final set in annual reporting. Our advisory committee is going to continue to meet to ensure the work stays relevant at the local level. In the next few weeks, our final report will be posted on the PHO website and distributed along with a shorter, more visual summary. We have plans to develop a performance measurement learning tool for public health units with support from Public Health Ontario based on our project learnings and our experience presenting at the Ontario Public Health Convention. We have committed to reviewing the fit of the indicators when the final OPHS or Ontario Public Health Standards are released, to see if they still make sense. And Kim has applied for a grant to continue expanding on what we've done, such as looking at the next priority topics. I wanted to wrap up with a big thank you to our long list of partner organizations and the many members of the advisory committee, working groups, and other individuals who helped us get this far. So it is a very long list, and thank you all for your contributions to this work. Now I will turn it back over to Andrea to get us started on the Q&A.
Thank you so much. What a great presentation. I'm wildly taking notes, and I have a huge to-do list that I can't wait to talk to you about. We have a lot of really great questions. I'm grouping them a little bit, so bear with me. Those of you who asked a question, I might not phrase it in precisely the way that you asked it. So these are program outcome indicators. So they're measuring the change that the program is intended to achieve. Each public health unit is going to be designing and developing and implementing their own programs. So we had a question around the broadness of the indicators, that they're mainly downstream. How did you kind of account for all of the different programs and services health units are going to be implementing and then therefore measuring? That's a big question. just a little one to start off with.
Yes, thanks. I can take a first run at that one. So I think where we started was with the sort of downstream indicator, we started with the downstream indicators that were very specific to what each health unit might be doing in their individual programs. And yes, as we progressed through the project, that evolved to not only making them more broader, but also becoming more upstream. We had the opportunity to present a workshop at the Ontario Public Health Convention, and that was actually really great timing because we got to present our preliminary results and get some feedback during that session. And I think what became very clear was these aren't meant to replace the measurement that's going on at local public health units that you're using to plan and evaluate and inform your program plans. It's meant to serve as some way of being a measure of something we can do consistently that can show our impact at the provincial level and capture the importance of this work in a consistent way, knowing the importance of the local indicators that people still need to be collecting, that are often developed in partnership with community. Therefore, there's no way that those could be expanded to the provincial level.
Can I just paraphrase so that we all kind of understand? So the idea is that this is kind of a core set of indicators that are, I don't want to say generic because that's not what I mean, but can be broadly applied. And then there's still the hope or expectation that when folks are developing programs and program logic models, that they will also develop indicators that may be more tailored to the audience that's going to receive the program. So for example, behavior change indicators, etc. Is that right? Yay. Okay, great. Okay, the next question, and someone has asked this question and I'm really glad because I wanted to ask it too. Can these indicators, and I'm going to add, and the process that you use to develop the indicators be used for other topics and in other projects?
Well, I can take the first go at that one. And yes, that is a great question. I think the idea from the start of the project is that we were going to develop a process, test that process, and that it could be applied for other topic areas, within chronic disease prevention, perhaps beyond. And so that is still the intention. We've learned a lot from what we've done, and I think the hope is that if we were to move on to another topic, it could be a much more efficient process. I think there was one question also in the chat about whether some of the indicators could be applied to other areas as well. And I think that is, we still have some reflection to do about the process and how we might apply it differently. But the idea is certainly that we would refine the process and test it out again for another topic area. And on top of that, we have this proposed set of indicators. We still have a bit of work to do to finalize them. And some of them could either be made more generic for more cross-cutting indicators, or just simply the topic areas could be switched if relevant within the individual indicators. So I think there's a lot of efficiencies in that we don't necessarily have to repeat everything all over again from the start. But that is certainly the intention, is that we can kind of create a process that our team and others might be able to use in the future for future indicator development exercises.
Right. So I think this question is going to segue beautifully, and that is for you to just talk a bit more about the framework that you use to guide and to inform your work. And so I think that the attendee is asking about the process steps that you use to develop the indicators, which you had a beautiful slide on that.
Okay, so yes, at first I thought maybe they were referring to more of a performance measurement framework, which we unfortunately, we're lacking. That was one challenge and barrier to our project. But the framework in terms of the process that we followed originally was inspired by something called the Chinry process, which is a priority setting exercise for health research, essentially. There are other consensus methods that are often used for indicator development, such as the Delphi process, but we simply didn't have time for that. So we kind of adapted a research priority setting exercise for our purposes. We heavily adapted it, and we modified our plans along the way, again, in part on what we learned from the rapid scoping reviews. So with respect to framework, I mean, we learned, we took bits and pieces from what others have done and kind of created, to the best of our ability, a process that we felt was appropriate for our context and purposes and timeline, and followed that. And I think lots of things went well, and there's lots of things that we sort of learned that we would do a little bit differently moving forward. But I think maybe to answer the question, we sort of created our own process, but it was very much informed by, what others have done and what others have recommended.
That's amazing. And you talked also about evaluating and working with the health units to get feedback on that process. So I think that's going to be really useful for folks who are going to be developing indicators. The next question that we had is around engagement. There's lots of players in this space. There's a PHO, which is the Public Health epidemiologists. There is a provincial CQI group, continuous quality improvement. There is, of course, the Ontario Dietitians and Public Health Group. Can you maybe talk a little bit about those provincial players, kind of beyond the health units, and how you consulted, worked with, engaged them throughout this process?
Sure, thanks, Andrea. And really didn't get a chance to say it in the presentation, but we did also, the idea for this project came from the Ontario Chronic Disease Prevention Managers and Public Health Network, who prioritized the fact that we need to have consistent indicators across the province and really set up our working group for really strong engagement early on. So through that network, there's a number of those groups that report back and forth through the Ontario Chronic Disease Prevention Managers Network bi-monthly meetings. We were also reached out to the different groups that you had mentioned, for example, with a PHO, making sure that there was an understanding about the scope of this project versus the scope of work that they're doing on the core indicators. That's really looking at a population health level, whereas our project excluded population health level indicators. So at some point, those two projects need to connect to make it relevant across the whole scope of performance measurement and indicators. Ontario Dietitians and Public Health, we conducted a presentation with them early on, as well as tapped into that group to help us with definitions, and many members were part of the working groups that we had throughout the project. Any other to add, Vincent or Kim, that I might mention?
Oh, sorry.
Oh, sorry.
No, go ahead. Anything else for that question? Okay, the next question is about feedback from the Ministry of Health on these indicators. You mentioned that you've been having ongoing conversations. You're hoping to secure additional funding to keep working on other indicators. So the question is around, are these indicators resonating with them? And is there conversation about public health units using them in future annual service plans for chronic disease prevention? That's a magic 8-ball question.
I mean, we started this project with the intention that they would be picked up and widely used. We have been making sure that the Ministry of Health is connected to this project, and we're keeping them informed. I think there is interest there, and there was support for the project. For example, facilitated us getting access to the anonymized indicators from the ASPs. So that was an extremely helpful part of our process, given that we only had 9 months to do the work. So we haven't had the conversation with them yet about this final set of indicators, but if in reviewing the draft OPHS for the consultation period right now, I do see some alignment there. So hopefully there's room to build that in. Speaking
of the new OPHS, we did have a question. I was going to save this for the last question, but since you've mentioned this already, those draft standards were not available when you started on this project, what feels like 5 years ago. So now that you've seen the draft standards, do you feel like your indicators still make sense? Is there alignment with the new language and the broadness of the new standards, or at least the draft standards?
Yeah, I think from what we've seen, there is pretty strong alignment. And of course, noting that they are draft, and when the final set is released, or the final standards are released, we will have committed to doing that relook at them and seeing if they still make sense. It was always on our radar that we were starting this process during a time of potential change in that document, which would influence what public health units are measuring at the local level and potentially even doing at the local level. So it was always in the back of our mind, but we didn't want to wait, because we knew this work was complex and would take many iterations to get to the right spot. So we proceeded with that in mind, knowing we would have to adjust.
The only thing I would add to that is that when we were doing the prioritization survey with the 35 and trying to narrow it down, we had a whole category of indicators related to, say, developing personal skills. And it was pretty clear from the feedback we got in terms of feasibility and usability that that's not where health units wanted to focus, which is why in the final 9, you actually see 5 out of the 6 are focused on partnerships. So I think there was some kind of natural alignment just through that process that came up. although as Shannon mentioned, we are open to continue to revise based on once the OPHS comes out in its final form.
Great, thanks. We're making wonderful progress through these questions. Okay, we have two left. One question is someone wondering where food literacy and food systems work fits in with these indicators. What a great question. Who'd like to try that one?
I don't mind taking a first go at it. So for the food systems work, I think we mostly saw it captured in the partnerships type piece as well, depending on how, what area of food systems, maybe some of the monitoring food affordability or settings as well. So in that broad sense, that's where we saw it captured and where it could be described in the narrative portion of the sub indicators. In terms of food literacy, I'm trying to remember, but I recall we had a specific question around it that we had tested, and I don't remember the details, but I remember that based on some of the results, a specific indicator around food literacy didn't make it into the final or the proposed set. But I'll pause there and see if others have any other memory around that. And the only thing I'll add to that is it could also fit in that partnership piece because a lot of the food literacy work is in those settings that could be selected as part of that question.
And the policy indicators as well, I would imagine.
Yeah, so I'm just pulling up because we have draft response options for the sub indicators. So to Vincent's point, under partnerships and policy, we have a topic areas sub indicator, and we have food literacy and food systems are options for food and nutrition topics under both the partnerships and the policy indicators. So yes, I think there previously was a food literacy amongst program participants indicator that just didn't, like, because of the feedback we received, that ended up not being in the final set.
Okay, great. So the last question that we have is just around the different contexts that different health units work in. So the example that was given is that a large urban public health unit like Ottawa or Toronto might require more partnerships than a smaller or more rural health unit might have. So how can you account for those different contexts with the indicators?
Yeah, I'd like to take that one. So I think there's two pieces to this answer. I think the first is that we want to be very clear on what we're asking people to measure. So we do have some definitions built in, recognizing that it's not going to be maybe a perfect fit for every public health unit. We just want to make sure that everyone at least is measuring the same thing for that piece of it. And then the second piece is building in that narrative that came through loud and clear, that numbers don't say enough about the value and the impact of the work that we're doing. We need to have that opportunity to tell the story that goes along with the numbers. So I think that piece really fits in nicely there. So people are able to describe the work that they're doing by leaving that narrative piece a little more open.
So just as a way of kind of wrapping up, I know that you talked about this in your presentation, but I'm wondering if you can just summarize how you're going to be disseminating this information. And already my brain is a little fuzzy on the details. So if you could just remind us what's going to be happening with all this incredible information and how we can all get our hands on it.
So the report is almost finalized and will soon be shared on the Public Health Ontario website. As well, we'll be distributing through our advisory committee, which spans across the province, as well as through the Ontario Chronic Disease Prevention Managers and Public Health Network. We're also willing to come back and have conversations with any of the groups we did early engagement with, and would in fact like to loop back to those groups to continue the engagement, because we know we don't have a final set of indicators in front of us. We know we still have a little bit of work to do to test those and further refine them. So we want to tap back into those resources across the province. So we will share the information that we have to date, but we also want to still gather feedback.
That's amazing. Thank you so much. Any final comments from any of our wonderful panelists before we close today's session?
Just thank you, everyone, for joining today.
Yes, and thank you to all who participated as well. It was definitely a collaborative effort.
Well, thank you so much to Shannon Robinson, Kimberly Harding, and Vincent Ng for presenting. I also want to thank everyone who has joined us. We've had about 150 people on the line today. Thank you, panelists and presenters, thank you so much, everyone, for being here. Thanks to PHO Capacity Building for your wonderful tech support, and everyone enjoy the rest of your day.